two of them. There's a lot of months. So, Betty offered MRI. Just break so you ran collaboration. Very long. Building. All of those. I heard it. The problem is that next Thursday I'm not here. So I'm going to have to think whether we do it for May or do it one of the weeks after. Yeah, then Kay and I can.
Oh no, not tonight.
It's going to be staying together.
Just on TV. Okay.
So the private event. It's
supposed to be a public event, but it's on the
Hi, how's it going?
How are you? How are you?
Yeah, we were friends. How's it? Hi. How are you? And my glasses are on the last leg here. Yeah, I just thought that it's so real. Yeah, I'm not sure.
Yeah, I think that's announced.
I'm actually the next to say. Well, you do have people to look at this one, so and expect a lot. Hopefully, sitting the best. No, the yeah, she has to look this side and so where do we put the slides? You go to the slides, right? I have to go. And then you will go to the side.
And I would play that.
Okay, let's look at it. Well, you want to get can you meet them? Get you
Oh, you sharing your slides.
maybe share your first slide, just and then we know how all this works. Nana? You check in the lobby. Oh, okay. Oh, that's perfect. That works very well. Yeah, perfect. And we are at 11, so I'm going to. So good morning, everybody. Very warm welcome to everybody. I see a lot of familiar faces, but I also see a lot of new faces. And that's really why we have this presidential lecture, is to introduce new concepts, new people, new areas of research, but most importantly, areas that align with the SAMRC's mandate and our particular areas of interest as we go forward. So today I've got two very special guests. One of the guests are going to introduce the other guests, so I'm not going to take that part. But what I am going to do is welcome everybody who's online. All of our colleagues online, quite a few of you. At the end, where we have a question and answer session, please, you can put it in the chat or you can just unmute or raise your hand. And then we've also got two additional very special guests. So you can see Dion Salamo is, no, that's not Dion. I'm sorry, I don't actually know your first name. Kevin. We've got Kevin with us, and you can see that this lecture, therefore, is in the 12 official languages of our country, and you could do the transcript for the other 10, but it's wonderful to have Kevin with us today. And then we also have a very special guest in terms of family member, and there's something very special to have the opportunity to speak in front of your family. And so a very warm welcome to you and to the team that represent as well. So today we also speak about the importance of collaboration and how people have built relationships through research and through common interest. That's what we're doing with everybody here, but that's also what our two special guests represent. So they're going to talk to us not only about their research, but also we'll hear about the relationship between them. So I welcome you all. Thank you for coming to the SAMRC. For those of you who have not come before, please let this not be your first time. For those online, know that everything will be recorded so that we can also disseminate afterwards.
And after the meeting, there's some refreshments, so you can have the opportunity to speak to our two guest speakers. And with that, I'm going to hand over to the South African Women in Science Award winner, which is a huge achievement. So Professor Johannes Hancock, one of the first people I met actually when I went to Durban, when I arrived at the MRC, and who warmly welcomed me at that stage, and I warmly welcome you today. So Joel, I hand over to you. Thank you.
Thank you very much, Lisa. It's a pleasure to be here, flew in yesterday. And so I have the pleasure to introduce Harsha and her work, and also open the first presidential lecture on disability, which I think is really an amazing achievement for us as a group that works on disability. And Harsha is going to take us a little bit through the struggle and achievements of this kind of research. So first of all, maybe saying disability is something that affects actually everybody eventually over a lifetime. Yet it's something that is very marginalized in the corner somewhere, as if it is a very minority kind of thing that people experience. We're all interested in research and innovation. We know that research has taken us to be able to travel to the moon, maybe Mars, you know. We can build AI and robot systems that are actually beyond the abilities of humans, right? Yet we will find children that cannot see properly without glasses in the classroom, right? And that is the kind of thing where Harsha is going to take us today to. Our own research at the MRC has also evolved. In terms of that, we have started doing disability research, some of it focused and some of it mainstreamed. What we do know is a lot of those things around the gaps and the inequalities of persons with disabilities. And again, Harsha, you're going to show us some of that work, so I don't need to go ahead of that. I think the time has come for us to also look at innovations that can solve these gaps, inequalities. So go beyond the descriptions of what is wrong and develop the vision and also practical solution for inclusive practice in Africa. And that is exactly where Harsha is coming from. So Harsha Kathard is a professor at the University of Cape Town in the disability unit there. Before she has been speech therapist. That is your home, right? All of us with disability researchers, we got a home somewhere. Like my home is an education of psychology and education. I've done that for 10 years. And Harsha comes from the speech therapy, right? And you actually have a practitioner experience before you even came to do research. That's very often the case for disability researchers. It's like 10 years, or sometimes even longer experience, which makes us very practical, right? In a lot of ways on how we look at things in terms of solutions. Then you have gone into education after that. So you have seen our speeches very directly connected to that. And you started your academic career, right? You also have gone then later into disability studies, which is your home now. And you are the founder of Inclusive Practice Africa. And you can already hear on that kind of name for this group that this is not just describing a problem. It's looking for solutions. And this is where Harsha and I also started to meet. Like my first experience with research was when I was asking about disability. I was told it's 1% of 1%, it's not important. I wanted to know if persons with disabilities are also affected by HIV. It turned out they're twice as likely, and they are at least 16% of the population. So over times of 20 years. That I'm standing here now for my first question 20 years ago. And the practical solutions are now really the questions of how do we include persons with disabilities, for instance, in HIV service delivery. The same question has been asked in GBV, gender-based violence. And again, we're getting this twice as likely for women with disabilities to be affected by gender-based violence. Imagine in a country where we have high GBV, what that actually means. And that doesn't even include the discussion around what is disability-related violence, which we're also discovering there's something added on now. So this is kind of what disability research looks at, like what are the specific vulnerabilities and what can be the solutions. And I can see that some are here from the burden of disease, from mental health, from TB. Like if you look into any other disease, if it is malaria, TB, other than HIV, STIs, maybe even something like unintended pregnancy, discussed, or NCDs, non-communicable diseases. And you cannot answer the question on what is the percentage of persons with disabilities having that particular health conditions. Why do they not come and present at your healthcare services? Why don't you see them there? Why don't they come there? Don't they have the disease? Oh, and if you cannot identify why they cannot access that service and what may be needed, then you know you got a gap in your research and in your innovation, whatever you're doing in terms of research and innovation. And I think, Harsha, you're going to take us through some of the things that maybe is in our thinking that need to change to make our research maybe more inclusive. And maybe sometimes we also need some very specific research where we're looking at almost like twin track approach, mainstreaming versus sometimes looking very specific, specialized. And with that, I hand over to you.
Okay. So thank you for that, Jill. And thank you to everyone who's in the room for joining us. Unfortunately, I'm going to be looking that way for most of the time because of the camera. But I just want to welcome everybody and say thank you for joining in the room and online. And to Professor to Jill, Professor Ntusi, thank you very much for putting disability inclusion on the health agenda or on the health equity agenda. And perhaps to start, I just want to say that this issue is personal to me. So my presentation today is in honor of my parents, Mr. Mohila and Kathard, who would be 90 years old tomorrow. It's late, and my mom, Kamla Kathard, is in the room, as you all see. And their lives and our lives with disabilities gives me first-hand experience of what it is to be in a house facility that is not designed for you. And it is with that in mind that we think about what we're going to talk about today. So as the overview of the presentation, I'm going to start the presentation by sharing my perspective on health equity through a research account of Mrs. M's experience. I then go on to explain why we must be concerned about health inequities, as Jill has explained, faced by persons with disability. Thereafter, I will share historical reasons for why we continue to experience this injustice, the marginalization of persons with disabilities. I then explain how research, which is the knowledge we generate, plays its hand in relegating people with disabilities to the margins. And then I close by sharing how African research excellence is a growing space of possibility in addressing health inequities experienced by persons with disability. So when we think about health equity, I'm just wondering, for everyone in the room, what are you thinking? And if we had more time, we would be talking a lot more. But today we don't have that time. But I do want to take you through Mrs. M's story, a research story generated by Tess Pudiachi in her PhD study. And it is through this that we can learn about what health inequity means, what it's experienced as, and why we should be concerned. So let's listen to this account. This is from Tess, who started off by telling me that it was a very long, difficult walk to Mrs. M's home, a dwelling in the informal settlement deep in the Clare State Valley in KwaZulu-Natal. Mrs. M smiled as she welcomed me, together with her daughter and her 3 grandchildren. Mrs. M had a spinal problem as a child, which she was born with, and she struggles to walk without assistance. She receives a disability grant, which now will be around 2,200 rands per month, which she uses to support her family as there is no one else. And then she hands over to her daughter to explain. And this is what her daughter said. Yes, she has BP, that is hypertension, and sugar, diabetes. So it is her BP that is worrying her too much. I think it is because of the place that we're staying in, because the people here are always making a noise. They're always fighting. She's trying to separate them, trying to talk to them. And that's the thing. It makes her BP go higher every time. The place that we live in, she says, it's not good for her. She can't move here. She can't go to the toilet freely because the toilets are too far away. And so for her medication, we hire a car, and the car costs us 150 rands. And then she points to this makeshift bridge that you see in the picture before me. And she says, so when we have to go to places, we have to hire boys to hold her, to pick her up. If she can go down this passage, it's very, very difficult for her to walk. And she's got a sore on her leg. And those sores have been there for years. When she gets to the clinic, the nurses know her and help her with a wheelchair. She doesn't join the queue, which is good. It's not taking long, not even 30 minutes, because all this time we have to hire somebody. We get medication and we go home. So listening to Mrs. M's story, the question again is, does Mrs. M experience health equity? Yes, no? Okay, so the way to answer that question is perhaps by thinking about, does she have fair and just opportunities to be healthy? Have systemic barriers to healthcare been removed? Is her health negatively affected by social determinants such as poverty, stressful living conditions, racism, education, etc.? And I think from that story and from your nods, we can say safely that Muslim doesn't experience health equity. And that's a goal for us as South Africans. And therefore, we must be concerned. So we must also be concerned because this problem, the story of Mrs. M, is a story of many, many people. And as Jill mentioned, when we think about disability, we often think about a small number, but 1.3 billion people in the world isn't a small number. 80% of whom live in low and middle income countries, and that makes about 16% of the population. In countries in Africa, we estimate that this is higher due to poverty, malnutrition, and social living conditions. We should also be concerned in South Africa because 15.7% of people with disabilities is what was counted in the Stats SA 2024. But in a different survey, that's the demographic and health survey data, we're getting to a different point, and that is getting very worrying. 22.2% of people with functional disabilities, and that's something we can talk more about. But here's why we should be very worried. When we think about multidimensional poverty and disability and what that means. And I'll give you a moment to just look at that graph. And Julie's here smiling at me because it's what she did. So thank you for that, Jill. And I think when I look at this graph, or when I even hear the words multidimensional poverty, it really makes me feel angry because it seems like we invent new words to describe multiple deprivations that people face on a daily basis. And that while this might look like a graph, it is the lived reality of what people face on a daily basis. And what this graph is saying to us is that people with disabilities, especially severe disabilities, are on the margins of society. They are among the poorest people. And although we have poverty that we should be very worried about, it is people with disabilities that are more likely to be poorer, and the poverty disability cycle really does with itself. So multidimensional poverty and health equity, we know, are serious concerns, or health inequities are serious concerns. But let's go to a different point about disabilities themselves and think about what or how we make sense of disability, because as Joe was talking about it before, it's a big topic and often misunderstood. And so when we think about disabilities, and again, why we should be concerned, it's about the misunderstandings around disabilities themselves, how people with disabilities are misunderstood in everyday settings, and particularly in health settings. So when you think about disabilities, and people often ask me, like, you talk about disabilities, what do you actually mean? And sometimes I want to say, actually, I don't know anymore. I don't know anymore because it's a very complex human condition and it's very hard to define. And I hope that as we learn and we grow, we will learn how to redefine what it means to know disability. But for where we are now, when people talk about disabilities, they often mean impairments, or they're talking about impairments, and particularly in the health professions. So we look at disabilities as a catalog, literally, of impairments that can be physical, sensory, communication impairments, neurodevelopmental, psychosocial, intellectual, cognitive. And I'm not going to go through explaining what that list is, but I do want to say that these impairments limit people's activities and participation in everyday life. But the important takeaway point here is that this is only half the story. And this is often the only story that is told about people with disabilities. It's what deficit you have, what impairment you have, and it makes it an individual's problem. So when we go to the doctor or we go to the therapist, we have to fix the person. And that's really not what disabilities have. But let me carry on. Because impairments can be congenital and acquired. That means you can be born with it, or you can acquire disability at any point in your life. They can be visible or invisible. And it's really the invisible disabilities. And Jo here herself educates me about that all the time. And children and adults both have disabilities. So the other half of the story is really about the social barriers to inclusion. Because people who have impairments become disabled when they are systematically excluded and marginalized in their community, in health systems, in schools, in workplaces designed for and by people who are so-called able-bodied and able-minded. So if this is your takeaway message to understand what disabilities are, then it's not just about people's bodies. It's about how they discriminate against and how this is done systematically across every sector in life. And so that, I think, is a place that we could start with understanding disabilities. But when we think about health inequities, and we started with the data, and if you look at the missingbillion.org website, here's what it is. You will see that people with disabilities experience worse health outcomes and a staggering 10 to 20% life expectancy gap compared to peer persons without disability. You also see a higher prevalence of health conditions amongst persons with disabilities. And here we're talking about breast cancer, HIV/AIDS, and COVID. We see higher personal health expenditure. And I do want to make a point of that because I think when we think about disabilities, we often even think about health conditions. And we know that people who experience difficulties, families have a very high burden in terms of the tasks that they do. The other important point, and again, why we should be concerned, is that the bidirectional nature of disability. And so when we have health conditions such as cancer, then cancers can cause disabilities. But the other direction is that people with disabilities have a higher prevalence of cancer. And so this bidirectionality is something that we should be concerned about, because most times, as we were saying, we don't think about disability when we're thinking about cancer. We don't think about disabilities when we're thinking about heart disease. We don't think about people with disabilities when we think about mental health conditions. But the experiences of disability in people's healthcare settings is, again, another place that we must be concerned about. And so here, Sally, talking about her experience of sexual and reproductive health and the barriers to healthcare. And here's what she says. If I deliver a baby, and Sally is here, if I deliver a baby, no one tells me how to care for it. The nurses are just angry that I am deaf and I'm having a baby. They think that I have evil spirits because I'm disabled. They cannot speak sign language, so they teach me nothing and I go home. And there's no one to teach me. My mother and father both died of AIDS. The babies, some of the babies of my deaf parents died because there was no one to teach them how to take care of the baby. I was lucky because there was a clinic in Kathard, and there was a nurse there who had 2 deaf children, and she helped me to deliver my baby, but she did not tell me how to take care of it. But I am happy. I figured it out all by myself. This experience is not a one-time experience. And in a spoken review of studies in sub-Saharan Africa, Dante et al. Indeed found that these experiences were common and that health facilities are systemic barriers for people with disabilities. So there's another reason why we should be concerned. Kevin, I'm just checking that you're okay. So Kevin's our sign language interpreter. When he tells me he needs a break, we will take it. All right, so we want to then understand. So you have these problems. They've been long-standing, they're systemic. People are excluded in almost every area of life. How did we get to this point? How did we get to this point in South Africa? How did we get to this point internationally? But it is Africa that we're concerned about. And so I'm going to talk about then the history. Where does this all come from? And we often talk about this colonization. We talk about apartheid, but not always in relation to disabilities. And so this picture is a disturbing picture. But I just want to think about, what it means to understand the long-term effects of colonization as well as apartheid. And that when Africa experienced such long-term impacts, Ned reminds us that this was a violent system and it had a very heavy hand to play in the disablement of people in Africa. Disablement in many ways, not just physical. Colonial violence resulted in the maltreatment of slaves leading to disability. And here you see the giant images of slaves who had their hands cut off because they weren't meeting the daily quota on rubber plantations in the Congo. Frantz Fanon reminded us that Black people were treated as less than human, and this resulted in mental illness, which became disabling. We also know that during this time, indigenous systems of care for people with disabilities were replaced by institutionalization. Forced labor and appalling work conditions, living conditions, chronic illnesses also led to disabilities. And so the question I'm asked always, so why should we be bothered that was in the past? And if we think if it was in the past, then the answer is also no. It lives with us in the present in many different ways. And how it lives with us is through coloniality. So coloniality is what we've inherited, what we continue to practice, and what we, again, should be concerned about. Because colonial injustices in research, in health systems and education perpetuate this very problem. So when we see these problems, when we meet them every day, they didn't come by accident. It is actually a practice that we still perpetuate. And so when we see unequal and segregated health systems, when we know that there's a divide between public and private health, when we see Eurocentric dominant curriculum and health practices, the devaluing of indigenous people and their practices, particularly spirituality and healing, entrenched racism, sexism, and now we're going to learn more about ableism, heteronormativity, among others. The health practitioner who has power over the patient has all come from colonial system of injustice and a system which reinforces health capitalism. And don't we all feel that every day as the costs of healthcare go higher and higher, and people feel that this is more an industry for profit. And very importantly, the persisting burden of disease and then disability erasure. And disability erasure is interesting because it's something that nobody talks about, even when they talk about colonization. That means people with disabilities have remained invisible. And the plight of people with disabilities have remained invisible. These are the people that almost don't exist, who don't count. They don't count when we do data, we don't count in real life. And this is really a colonial injustice. It comes from thinking about who's important and who's not. But it is the dominant colonial knowledge. Because we're talking about research today, we are at SAMRC, and knowledge is what we're interested in. Then what is coloniality of knowledge, and what does that mean for disabilities? Okay, Kevin, how are you?
Okay, Prof.
Are you ready to carry on? Okay. So everybody in the room, okay? All right. So we think about positivist science. And we can get into this because during colonization, it was people who were considered other, Black people, people with disabilities, gay people, gender diverse people, all the people who didn't fit the norm of the empire. The empire, in turn, created binaries of what or who is normal and abnormal. By adopting a positivist science, it used measurement, observation, and verification to decide who was normal and who was abnormal, and then to seek a biological basis for what caused that abnormality. Specific to disabilities, those who fell outside of that norm were labeled abnormal, crippled, handicapped, invalid, or invalid for society, idiot, lunatic, and all derogatory terms. So all deficit terms, all dehumanizing. As a consequence of adopting the science uncritically, medicine shifted its focus from listening to people with disabilities to observing them, deciding who was abnormal and normal. This meant that the problem lay again with the individual who should be treated, fixed, so that they could fit back into society. Foucault described this problem or this practice as the medical gaze, which gave the doctor surveillance and control power, while simultaneously diminishing the focus on the person and their content, setting the stage for health inequities. This normative practice was spread to professions and people responsible for the management of persons with disabilities, medical doctors, therapists, charities, education, social workers were all among the people who became part of institutionalizing the practice of ableism. And so that is how we have ableism officially being part of our practice and something we really do need to reflect on. People with disabilities rejected this reductionistic understanding of themselves and named it the medical model of disability. And this should not be confused with medical care. In response, the social model of disabilities was then offered by Mike Oliver in the 1980s, was a person with disabilities, and this focused on social barriers to how disabilities are created. So this is, I think, when we think about how we got here, a scary science, a pseudoscience, a science of discrimination. But eugenics was a movement that I think we know about and we should be ashamed of. It was part of colonial conquest, regarded as a pseudoscience, which was intent on creating a superior master race. It entrenched ableism by seeking to eliminate the reproduction of people who were a threat to this race, to this master race. It also used the tools of measurement, as we see in the picture. We see a person, a Tibetan woman's head being measured to demonstrate the inferior characteristics of her race. While the picture on the right is a young girl with a cleft lip, taken to demonstrate the type of child who should be kept from breeding. The research which objectifies people with disabilities, as well as the research on scientific racism, both share the troubling parallels in their methods of measurement, in pathologizing difference, and upholding social hierarchy. Ableism, therefore, runs very deep in creating what we call, or what we know as, the master's trope of human disqualification. The eugenics movement also led to the large-scale sterilization and mass extermination of people who were thought about as a threat to the master race. So let's examine how then ableism, that is the discrimination of people with disabilities, systemic, feeds into research. And we know the story. If you don't know the story, read it up, of the Willowbrook State School, where there was medical experimentation with institutionalized children who were regarded as mentally defective. And the study was important because it was a study which used children in an institution to, as experiments, to trace the development of a viral infection that was prevalent at the institution. But what it did was raise many ethical concerns about the maltreatment of children with disabilities used for research purposes. Again, thinking about how science decides who counts and who doesn't. But if we think that's long ago, in our clinical trials, there is exclusion of persons with disabilities. And in the study by Tsunami et al., this is as recent as 2023, it shows the systematic exclusion of persons with disabilities. And this raises questions both about the science and ethics of leaving a group of people who are more vulnerable out of clinical trials. How do we explain this? Is this an ethical practice? Is this a good science? And how do we continue to work with that? We also found that there were no studies that examine disability in relation to diseases of blood, diseases of the immune system, diseases of musculoskeletal systems, or conditions related to sexual health identified. And so again, saying where are the areas where we see no research on that is related to disabilities. But I think for me, what was really encouraging was that since 2020 to 2026, the awareness of ableism in health disciplines has become encouragingly visible. And so this may be the start of thinking about how ableism can actually be used as a way to think about discrimination in our professions and how that actually helps with us looking at a pathway through which we can achieve health equity. Because if we as professions continue to reinforce such discriminations, then we also part of the problem because we create the systems and we create the practices. And so across all of the professions and disciplines, I think what we're seeing is a very deep reflection now on deficit, individual biomedical understandings of disability. And I hope that is going to take us to a different place in respect of how we move forward. But ableism is also evident in health professions education. We don't learn about disabilities. It's absent in our curriculum. And again, it's not by accident. Educators are not prepared for disability inclusion. Graduates are underprepared for disability inclusion. And staff and students with disabilities are underrepresented in education as well as in health professions. Again, saying this is no accident. There's a reason for why people get excluded. And so health professionals, in terms of continuing professional development, lacks a focus on disability inclusion. And so when I looked at the literature, I think what I found really interesting was that the disruption within the health disciplines is coming from people who have become disabled while they've been practicing. And it is the internal disruption that I think is saying to people in the professions, but now I don't fit in, and now you're rejecting me. You're telling me I can't practice, not thinking about what disability really is, because the focus again is only on impairment. And I think that's something that we can all learn from. Just checking you're okay there, Kevin. All right. So when it was about 25 years ago when I found myself in exactly that same position of feeling like there was something I was doing in my practice, in what I was teaching students, that was discriminatory itself. I didn't have a word like ableism then, but I knew there was something that needed to be done, something more that I could do in my research and my practice. And so I decided that I wanted to do a study that was really different. I wanted to hear the stories of people with communication disabilities rather than stand on the outside and measure who they are, measure their deficit, how many times they stuttered, how many times there were communication breakdowns. Actually hear a story from the other side, from the person who lives with an impairment. And so it's no surprise then that my PhD proposal was rejected in health sciences. I wasn't allowed to do it. They told me, real science, take it away. We don't want to have anything to do with your research. And so I left because I thought, well, the question was far more important to answer than a health sciences faculty, because it was a case that actually hadn't thought further than a biomedical model. And I'm glad I did, because that opened up a whole world of new learning for myself. And it really allowed me to understand that we cannot continue our science in this way. And so I'm very pleased that as we sit here today, we can talk about African research in excellence through disability inclusion and how that will pave the way for thinking about disability inclusion, for thinking about health equity in different ways. And here I want to start with research excellence by talking about disability studies in Africa. And it was, I think for me personally, one of the most interesting spaces when I got to UCT and to Cape Town to discover that it was actually a disability studies program. This was the first in Africa that was started by Professor Teresa Lorenzo, and our current head of Division of Disability Studies, Sumaya Gabriel, is here in the room. And disability studies did something different. What they did was adopt and is adopting and Ubuntu African ontoepistemology, so all the big words, meaning that they're rethinking about the worldview that we take when we generate knowledge, shifting from a positivist approach to something that brings humanity to the center. So it's essentially anti-ableist. It is researching with and not on people with disabilities, their families and communities. People with disabilities in disability studies are researchers and not only knowledge consumers. it takes very much an intersectional approach, considering some multiple oppressions. So nobody can ever just be a person with disability. You always have a history, a culture, race, sexuality to understand the complexity of human condition. And then it expanded the range of research methods to include narratives, critical ethnography, community-based research, as well as arts-based research, among others. So it was a deliberate expansion of the focus from disease, disorder, deficit to inclusion. And I think this discipline has really added great value to how knowledge is generated around disabilities. But this isn't enough. Because if we leave disability studies, and that's been my observation over the years, it too becomes a silo. It too becomes a discipline on its own, talking amongst its own. And Jill and I know the story very well. And we now have, and I'm glad Professor Galfan is in the room, because we have thought about what we call our DIRCLES project, which is Disability Inclusive Research Capacity Development, or going for systemic change. And this project is really to interact with health research teams, to unpack disciplinary ableism, to look at ableism and disability research or inclusive research methods, to reframe research questions which address health inequities. So this approach is about building inclusive transdisciplinary knowledge, which is essential for addressing health inequities. And so we feel that if disability study engages with health disciplines, this is really where the value of knowledge transformation lies. And if this knowledge is implemented, then I think we have a chance at being more inclusive. So we invite you all to DIRCLE with us. But I want to mention, and say, I'm glad you're in the room as well, disability inclusive surgical case study. And why I'm mentioning this in particular is because every discipline that wants to look at it is got a champion somewhere, somebody who feels this is important and I really want to know how we can build surgical care to be more distance. And so you will perhaps later share his personal experience. But the other reason I want to mention the study, a special mention, is that typically medical doctors don't do research as undergrad in their undergraduate studies. And as an undergraduate student in fifth year, to take this initiative and to make sure that research that is important needs to be done, challenging a whole discipline or thinking through how we should do disability inclusion inclusive is really important. Now, Jill has been so busy, and she can tell you a lot more about this than I have. But Jill, and together with Bradley, they've led the initiative on the Disability Data Initiative in Africa. And this is very important. So although I've talked about stories and all of the different methods, it doesn't mean that this is a rejection of quantitative methods, because it's not to be conflated with positivism. But importantly, that data in numbers also tells us a story. And what this map is really showing us is about where we are in terms of disability data across the world, and what we need to do more to build this database to give us the kind of data that we need to help us make decisions. And Jill can explain more later, but I think the Disability Data Initiative is important, and we know in South Africa that there is also a framework for how we harmonize data. So when we collect data, it's like one set in health, another set in employment, another set in education. And somewhere along the line, we need to put this picture together. So when Jill and I were talking and when we met, I met her while she was doing this study. So we know that clinics are not prepared in terms of disability inclusion. And I guess both of us are kind of action orientated. So we like, let's look at what we could do differently. And so Jill and her team have embarked on an extensive study in KZN of 47 clinics, in which we look at, she is examining how prepared are clinics for disability inclusion. And this is through the Disability Awareness Toolkit, which is worked through with clinics or nurses and clinic staff in general to see how clinics can be more disability inclusive. And I think what is interesting are the findings that are emerging, and Jill reminds me these are just preliminary, so she's going to work a lot more on them. Now, the graph looks quite complex, and it's got a lot there that we can talk about. And I just wanted to say that in this particular data set, what we're seeing in green are the points at which the clinics are well prepared or better prepared. And this is, for example, in the entrance to services, reception rooms, etc. I think we're getting more aware at a physical structure level. Where we're not doing well are the points in red, which is about accessible information and communication, the training of health workers for disability inclusion, screening and referral, because clinics at this point do not have a DOH approved screening tool for disabilities. So if somebody is in a clinic, and in the workshop that we had with nurses recently, they said, we don't understand disabilities, we don't have a screening tool, we actually don't know what to do. So at the very first point of interaction. And that there is also a significant gap in linking to other services. So this study is very much on the ground. And as a consequence of this initiative, what we've done is already developed a training program for health practitioners, which looks at gender-based violence and disability as a short course that people can do. And that will be fully online as a self-paced learning course launched in June this year on the UCT platform. And that is a collaboration between MRC and UCT IPA. So we're very happy for the practical nature of what the study offers. And then the question, of course, that everyone asks Jill, how much is this going to cost if we have to do clinic readiness for disability? And Jill is estimating that this will be about 1 to 2% of the annual DOH budget. And this is going to be very interesting when we think about it. But I think that an investment in long-term change is very important. And we can share more details of that costing. And I think one of the big aspects of what Jill has found is that the costing is of very, very basic services, very basic things that need to be done, and a lot that can be done without much. So we can turn it around in what we do. And then to move on, just to say that we've done a lot of research. I think, Jill, when we talk in IPA, when we discuss amongst ourselves, there is a lot that we know now. For example, we know that rehabilitation care workers help to achieve community-based rehabilitation care. This is a new cadre of worker that has been trained at UCT through the Higher Certificate in Disability Practice program. It's a one-year program that is NSFAS funded. So this initiative in terms of community-based rehabilitation in primary care has been tested and it works. Now we need the implementation. We need the Department of Health to employ community rehabilitation workers in primary care settings. We also know, and Prof. Kathard is here, about the importance of psychosocial disabilities and mental illness, and how we can shift, or we must shift, from a clinical recovery basis to a community-based personal recovery process. And really, when we think about it, and when I talk with Rashan and with Fadia, it's like this is something we really need to take seriously. This is a situation that we already have data. We know what that practice looks like. Now we must implement. Then importantly, to assess and improve health policies for disability inclusion. And here in Tessa's study, she's already found a way for us to do this in a research-led way, and now it calls for implementation. And then importantly, in the study by Sarah Whitehead, we've identified competencies for disability inclusion in the medical curriculum, and we now need to continue to work with that for implementation. Research ethics is also an area that needs transformation because it in itself, I think inclusivity as an ethical consideration isn't there fully, and something we need to consider. How we resist paternalism, positioning all people with disabilities as vulnerable, and then we exclude them from research. And I think that's important for us to think about. And then how to rethink ethics through the decolonial lens. And I think if Jill and I wanted to say something very important for today, it's about research funding for African excellence. Disability research has been on the margins, just like people with disabilities have been. And this is international. So disability research happens in small pockets mostly because it's small self-funded projects that people who are really keen on disability inclusion and change invest their time in. And I think now the time has come to embed disability inclusion research in health research grant calls. If we make those shifts, we'll start to see systemic change. We need equitable funding for disability inclusion between what I would call disease-oriented research and disability inclusion research. We need both of those knowledge bases for health equity. And if we keep leaving the research out on disability inclusion, we're not going to get there, or the time or the struggle will continue indefinitely. And Jill and I would like to see, and I think for all my colleagues in the room, we would like to see an African center that focuses on sustainable research in disability inclusion. While there is a lot happening, there is no collaborating center that brings us together. And I think for the fragile community that there should be a way to continue to sustain this. And I'm almost at the end, Kevin, and to everyone else. And I really want to just share a very positive story of how collective evidence-based action yield very positive results. And this is our friend, Jill and mine, the late Dr. Jacques Lloyd, who's worked with us, and he talks about research and implementation. Let's listen to Jacques.
When I started with the Civil Society Forum at the South African National AIDS Council in 2011, there was very limited disability inclusion. Currently, for the last 2 cycles, the previous disability plan, the National Strategic Plan, and the current National Strategic Plan that's coming into work now this year, is the most inclusive, disability inclusive plan in the world. And we worked on that. And the reason it is the most inclusive is because while it was developed, we worked with the Medical Research Council, we assessed the documentation that were drawn up, we identified gaps, we gave feedback to the disability sector, we got all the different disability organizations together. We had a brainstorming for 3-4 days on what needs to go in there. And it was an all-inclusive plan. And it was so nice to actually go back and say, here is what we want, based on evidence. Because since 2011, we were making an effort to do through various organizations, and you've been part of that, to do research on disability and sexual health. And by having that and the evidence, we could go and say, this is what we want. In 2011, in 2014, with the 2017 cycle, in the NSP that were written up then. They excluded disability from the Global Fund GC7 application on the basis that there's not enough research and that including disability will weaken the application. And this decision was made by the CEO of SANAC and the country coordinating mechanism. And I said to them, how can you do this? I mean, these people are the most vulnerable of all your civil society forums. And they said, but there's no evidence. It will weaken our application. And I said to them, okay, next time when I come, I'll show you the evidence. And we worked on it, and we've got the evidence today, and today we all inclusive. So I think IPA can play a major role in just strengthening on what is there already.
And so as we end and we conclude, just maybe a reminder that health equity will only be achieved when persons with disabilities are included, that knowledge matters, and disability health or inclusive health research is a key driver of change, and therefore this research must be prioritized. And to all of us, to be brave, to lead together with disability decolonial consciousness, as Africa must write its own narrative, a narrative in which disability injustice disappears and humanity resurfaces. Thank you.
I just really have to thank you so much for that most inspiring and comprehensive lecture. I think I wasn't really sure what I was going to hear, and I heard so much more than I expected, and actually feel quite challenged as a member of the SAMRC in terms of, are we meeting your challenge or are we falling short? We have tried in many ways to be anti-ableist. I think you've seen some of the placards around here. We have tried to teach ourselves at least greeting and telling spelling out your name in sign language. We've got access control, some of the infrastructural things that you talk about. But what you mentioned was the systemic changes. And I think we're all going to go back and think again about what we need to do to make sure, as you say at the end, we have a unified person-centered approach that actually speaks to the various elements that you raised. The other thing that I think is so important is that we know, we've heard wonderful data that's actually given us that direction, but we know the no-do gap can be so far apart. And how do we work together as a medical research council with so many other academics in this room to actually bridge that gap and bridge it quickly, because we really don't have time to wait 14, 15 years to achieve those things. I've seen some wonderful comments. You can read them, thought-provoking, inspiring, insightful, brilliant, still a long way to go to bring about equity. There were also one or two questions. I think I saw Prof. Naidu having a longer question, but perhaps I can open up to the floor and see if there are any questions from the audience. Also, if there are any questions to Jill or to any of the other members of the team here that are present in the room today. So I'm happy to open for questions. You can maybe just forward to that. I'm going to take the prerogative of putting you on the spot. It's such a joy to have a medical student doing research, and we heard about the work that you've done. Maybe you could just give us a very quick reflection of that particular paper and your approach.
Sure. So we're still in the protocol development phase, but yes, I'm in my 5th year this year, so recently exposed to the surgical side of things, surgical disciplines. But since the start of undergrad, we've got a really good global surgery division at UCT. So really been exposed to the concept of stacked vulnerabilities. So people who are pregnant or children who are especially vulnerable to during the surgical care process. And from my own experience, my parents are both deaf. So having to accompany them to doctor's appointments and that kind of thing kind of made me thinking, surely disability is also a stacked vulnerability that people have. And our surgeons and healthcare teams and anesthetists, are they capacitated to engage with deaf people when they come in for surgery? And yeah, it's also a communication issue. And I just thought, how can I look at this? And Prof. Kathard has been really helpful in helping me with that.
Yeah, I mean, a really excellent area to work in. And I think one of the things that I highlighted from Jill's work was the fact that the biggest red bar was around training, both introductory and advanced training. Some of you may know I'm a pediatric cardiologist, a pediatrician by profession. And of course, I did graduate a long time ago, but I don't remember being taught about disability and inclusion, even in the pediatric practice, except in a way to say, here's somebody different and you have to do things different. And so this has to be incorporated in not only our training of health practitioners, but our training of researchers. Many of the people working within the MRC don't work in the clinical space at all, but are looking at things like how does health systems work for them, issues around equity and vulnerability, and we don't know that this is something that's permeating through that as well. Do you want to ask that question? Joel, did you find it? Dr. Prof. Naidu, I think, said it.
Oh, yes, I've got it here.
It's a hand up.
Okay.
Oh, and there's a hand up.
It says disability is largely a function of ignorance and apathy. Are there any studies being conducted from the eyes of decision makers in large organizations?
For decision makers.
Yeah, are there any research that is being done from the eyes of decision makers in large organizations when it comes to disability?
I can share maybe a study which showed the influence when somebody in an organization has a positive leadership impact. But what I know is that there hardly is much research in that area. And I think that we definitely lack research with leadership, and how they make decisions. But that when leaders are aware, that is when we see change. So that's what our studies have shown us, is that when there is leadership adapt.
Yeah, I think the biggest barrier is actually access to the leaders. I think there are a lot of people who want to understand and consider the decision maker's opinion very important, but often we don't have access as researchers. Some way or other, you're blocked from getting to that point.
I thought another comment that you made that was so interesting to me was the fact that often that changes when somebody themselves experiences or comes from that background. And last year in August, I broke my leg or broke my ankle and had to travel overseas. And this is a temporary 8-week issue, but actually realizing just the fact that the barrier that the ramp that we have up here, you can't go up that ramp when you got crutches in one hand as well. And what it was like when I had to hop down the stairs in a plane when you're non-weight bearing, it suddenly gave me such a different look at what we had actually started to do within the MRC, but really not doing it well enough, simply because it wasn't our lived experience. And so really a very interesting comment from yours, and that shouldn't be the only time that you try and do those things. Yes, the hand that's up. Oh, there are lots of hands. I'm going to let Joel, why don't you?
I think Tendani cannot be.
Yeah.
Thank you.
Right. You, Michael?
You can unmute.
Yeah. Today, are you asking me to speak, Chair? Michael
Yes.
Samuel? Yes. Thank you very much, Harsha. Really appreciated being part of this conversation. I appreciate how you managed to look at the intersected levels of theory, practice, funding, policy engagement, etc., by feeding into a reimagination of health sciences. Here's my provocation. I think this kind of much more complex understanding of how we go about inclusive and decolonial practices is not only a discourse in health sciences but is also something that we should be exporting into other fields, other professions like law, like management sciences, like education. So I think the agenda might be not only just for health sciences. I understand this is addressed to the medical research community, but I think that your insight has the possibility to lever change on a broader systemic levels, because after all, we all are interconnected with the same social system that we work in. I'd like to hear your comments about that, Harsha. Thank you.
Thank you, Michael. And just so everybody knows, Michael was my PhD supervisor. He's not asking me questions. But Michael, so this particular talk was for health professions and health. But in Inclusive Practices Africa, we have different streams. So the one stream of work is on inclusive education, and we're doing exactly the same thing in inclusive education. Then it's inclusive health and inclusive employment and economies. And so we're working across all of those sectors because you can't achieve inclusive health without the other two, and they all interact all the time. So yes, there's an initiative to address each of those areas. I don't think any of it is easy, but I think framing it in this way helps us engage with the different sectors. So there's a lot of research that is being done currently on particularly inclusive employment and economies. And I think when we really can implement inclusion is when all of those sectors work together. Mm-hmm.
Then we got a question from Rashan or Rashantini. You unmute yourself.
Okay. Thank you, Chair. Thank you, Prof, for such a, oh my God, I don't even have the word, but it's heart-rending presentation. Many moons ago, I knew you as a learner, and today I'm coming to hear you as a professor. But well done. I just want to pick up on a few things. And as you rightfully mentioned, humanity is at the center, when we work with vulnerable populations, and that Africa must write its own narratives. And I'm just going to expand on that a little bit in relation to persons living with an albinism condition. Okay, so, if we go back to the African Disability Protocol, it's aggressively highlighted the unique experiences of persons living with an albinism condition. And how far have we gone there in terms of research, practice, and service delivery and things like that. And yet we do note that disability is a complex issue with various intersections, but the unique experiences of persons with albinism, how far have we gone on that? And because I believe there's a lot more that needs to be done. Last year at the University of KwaZulu-Natal, we gave much attention to the issue of albinism in terms of university-wide webinars, staff developments, lectures to second-year education students and things like that. But there is an health inequity as well in terms of sunscreens, lip balms, and cancer prevention and things like that. And also, what we did come to realize is that how is the health sector dispensing with things like sunscreens, lip balms, because it is an inequity if it's not being done at the level of how medication is being handled. So in that way, I shall believe that, this sector of the disability population, and we in Africa, they're still being left behind. I just thought that's food for thought. But once again, thank you for a brilliant presentation.
Thank you very much.
There's another hand.
And there is Dr. Kira, need my glasses. Dr. Quinn, yeah, see, with my glasses. Okay, yes, please unmute.
Hi. First of all, Harsha, thank you for a brilliant presentation, as usual. As a recently retired principal of a special needs school, just two thoughts and one for your comment as well, is that we always think of disabilities not so much in the line of intellectual disability. And one of the problems as schools that cater for intellectually challenged learners is that they appear to be normal outside the sphere of the school. So in the public and in the communities, they look as if nothing is wrong. And they have the very same challenge when they go to social development for their grants. But my more important question is, how do we bridge the gap between the school, the education fraternity, and the health services, where our learners with disability are then sent to the hospitals and so forth, and the hospital and the therapists there look at them for half an hour, 15 minutes, and come up with a diagnosis that is totally different from what the school has perceived and the interaction that the child has at school. So, what is it that we can do? We talk about disability as being universal, but there are different kinds. So generally, a term that was coined by the education fraternity is that intellectually challenged schools or special needs schools are the orphans of the Department of Education. We are the last seen to when it comes to education budget, to replacement staff and so forth. Just your thoughts on that. And by the way, for the house as well, Harsha has been or was my supervisor for my PhD as well. I see Dr. Pillay is here as well. And also Prof. Michael, who was very instrumental in my PhD. So thanks again. Thank you, Harsha.
Thank you, Kiran. Kiran, nice to hear you again. The challenge between health and education, I think, is longstanding, and it's still there. And I think this is where the leadership really needs to come on board in terms of disability inclusion, because the people on the ground feel what the trouble is, like you as a school principal, the parents report the same, the therapists also, but the systems that integrate the two are still not there. And so we still continue to see the discrepancy, like for a child that goes from education to health or the other way about. And I think that part of the problem is that we're expecting too much from parents, because the parents are making up that gap. The parents are trying to get between school, between health, and the burden of a huge responsibility of the system is being placed on parents. So I think that the leadership needs to listen, but more importantly, they need to act. And so engaging the leaders in disability inclusion, as Jill and I say every day, that's the next thing we're going to do, is really get to leadership, because if leadership doesn't learn, then I'm afraid we just replicate the problem.
And maybe also to that particular thing to add between the school and the health care facilities, to get that link, and that's what Liesel already had picked up with the red bars. There's a lot to be said about education, both of learners with disabilities and parents, but also of healthcare staff and teachers. And if you can show the bars there again, just to highlight how significant the problem is. So, on the side of healthcare services, so when we've talked to those healthcare facilities, to nurses, and one of the questions is about their preparedness, or a set of them, and we asked them obviously if they had any form of disability training, and those nurses in all the clinics we go on, except for 2, they don't have any. So that is kind of like why that blue graph there for training is so small. But the red graph, the red part of the, which is really long for training and education, it represents where no solutions are available. So that are accredited. So what we're doing when we're going in there, we're asking them, okay, have you done it? Have you got it? No. And if they don't, we've tried to give them advice on where they can get or what they must do, right? Because, and that's why we have started developing the courses now. At the time of this research, there were no accredited courses. The healthcare workers couldn't go somewhere and say, I'm doing an online or offline course. So if the healthcare workers cannot be educated about disability neither in their training, because it's not established yet in their original training, nor in service training, they don't know anything about it. So from that side, the linkages isn't there. And then the same for education about health, and maybe specifically sexually reproductive health and sexuality. We have a huge gap on particular special schools where we're coming from now, to provide what we already know works, which is comprehensive sexuality education, where you learn about your body, you learn about your rights, and you specifically learn also to prevent HIV, STIs, or unintended pregnancy. That specific way of how to provide that in an accessible format has also not been there at special schools for a very, very long time, not even included in the mainstream efforts. But there's a specific way of doing it to make sure it is accessible and responsive to those learners. And that is another thing we want to bring to IPA with the Breaking the Silence intervention. So it has been piloted, there is a solution, but it hasn't been rolled out widely. But what is there, and we will see how that will play out in the long run. As you heard Jack saying there that he went back in 2023, he came back with the evidence, because now finally he wanted to get into the plan, the National Strategic Plan. That's only the one on HIV, STIs, and TB, right? That needs to go in any of them. But in that one, the disability inclusion is in there. And even, I mean, he did instruct us, Carlo, what to do. Unfortunately, he's not with us anymore. But maybe a good thing to say that in 2024, it did go into the Global Fund application. So I do know that the Department of Education has allocations for BTS. Now it's a question about how that gets well accessed and distributed in the right sense, maybe. So I think to answer, I don't know if it's an answer, but to add to what you're saying, it's really about empowering the caregivers and the learners themselves, but also the educators, that they also don't know how to provide this information in an accessible format, and the healthcare workers. And that actually now needs research and innovation, because it's not that clear what works. That makes what enables educators to do this, or healthcare workers. What is feasible? How do we get to the 1 to 2%, right? So because you can't put the 50%, right? The Department of Health is going to say no. So that is a real question for research and innovation on how to make that work.
I feel really bad to have to say this, but we are at an hour and 21 minutes, and I can tell from the expression of everybody in the room, everybody's still rapt with attention. Lots of hands are going up, and there are more questions in the chat. But we are going to have to wrap this up. I'm going to ask those that have still had their hands up and didn't have a chance to put a question on, to put the question in the chat, so that we can maybe even disseminate that. We do need to give our Kevin a bit of a break and some lunch. But we also welcome all of you to join with our speakers, get to know them a little bit more, get to know us at the MRC a bit more, because I really think that what we've talked about is how we can collaborate, how we can work together, how we can address some of these gaps, and most importantly, find solutions that is inclusive and equitable going forward. So I would really like to thank you, Harsha. Really appreciate it. Again, my apologies from Tobacco that he wasn't able to join, but I'm thrilled that I was able to be here and hear such an extremely inspiring lecture. We've got people from overseas, so on the on the Teams meeting. So that's great. And then Jill, thank you for coming up all the way from Durban to be here with us today and for sharing your knowledge and your work as well. So to everybody, thank you so much.
We have not. Yes. Let them.